This week on Medstery Solved, we investigate the intriguing medical case of a girl who presented with abdominal distension when she was only 2 days old. The girl would then grow up going back and forth to different hospitals and will eventually have lung transplantation upon reaching 21 years old.
Well, that escalated quickly. I don't know how enlargement of my gut would lead me to swap my lungs with another person.
Want to know how it happened?
Yes, that's the point of this show. Enlighten me.
Okay then, let's get into it. CM, a 2-day-old child, was first admitted to the hospital due to severe abdominal distension and vomiting. An X-ray of her abdomen showed distended loops of bowel. She grew as a small child with her body weight and measurements falling below the norm. When she was 6 months old, she was vomiting and experiencing diarrhea for 8 days straight. The doctors found out that her renal function markers such as aldosterone and renin were quite high. She was given an intravenous fluid therapy and was discharged after correcting her biochemical abnormalities. However, she is always back in the hospital to be readmitted during hot and humid weather due to episodes of diarrhea and vomiting still recurring.
This story is very sad. Imagine being a kid and throwing up like a grown-up drunk person every time. That must have took a toll on her body fluids, indicating the presence of renin and aldosterone.
But what does that even do?
Our body compensates. The vomiting and diarrhea must have took her body fluids out or something.
Oh yeah, it tries to hold off water loss by decreasing water excretion.
Yep, you're right. But I must ask you this. Why did she have extensive abdominal distension?
As you can recall, the baby showed distended bowels or intestines. The usual cause in newborns is usually meconium ileus. This was confirmed using an abdominal röntgenogram.
What is meconium ileum?
It's when meconium, the earliest type of stool which contains mucus, lanugo, amniotic fluid, and water, causes ileal obstruction.
Did they perform surgery on the child?
Well, yeah, of course. They did that to save the child. It was also on the record that amniocentesis, a test on the amniotic fluid, was done. But I don't even know why they did that.
They usually do amniocentesis for infection, metabolic or chromosomal disorder.
But the results show that it was normal.
It's a little too early to say it's normal. This case is getting me hooked. Let's continue.
Even at 6 months of age, her diarrhea and vomiting still persists. She presented in the hospital as an underweight, short, and febrile child. Her blood pressure fluctuated between 70 over 50 mm mercury and 100 over 80 mm mercury. She was hyponatremic and hypochloremic. She was readmitted 5 times over a 2-year period, especially during hot and humid weather, with her diarrhea and vomiting still present. This time, she was hypokalemic. Her aldosterone and renin are also elevated.
We mentioned earlier that her aldosterone and renin are elevated, right? These are compensatory mechanism for loss of water and electrolytes during diarrhea and vomiting. However, excessive aldosterone causes potassium wasting, presented in the case as the increased potassium excretion fraction of 67% or hypokalemia.
Also, the fluctuating BP can be connected to hypokalemia since hypokalemia can cause abnormal heart rhythms. The kid grew up to be small that it seems like she's not getting enough nutrition. When she was 8 years old, she presented with severe gastroenteritis. A bizarre feature of her hospitalization this time is her sweat chloride level, which was 120 milliequivalent per liter. She was febrile and had marked finger and toe clubbing. Respiratory signs are now present. She had upper respiratory tract infection caused by H. influenza and S. aureus, confirmed through sputum culture. A year later, she presented with productive cough and greenish sputum, along with difficulty of breathing. Sputum culture now grew P. aeruginosa. Her infection must have spread through her airways because she now had otitis media and enlargement of adenoids and tonsils, along with bilateral nasal polyps. Antibiotics and pulmonary physical therapy were advised by her doctor. However, her disease progressed until she was 11 years old.
I am shocked. This kid's life must be hard. You wouldn't enjoy a life confined within hospital.
Yeah, I guess so. The unusual thing about this is that her very high sweat chloride and all those bacteria in her sputum.
The normal chloride content in sweat is only 10 to 50 millimoles per liter, and this child has an abnormally high sweat chloride of 120 milliequivalents per liter. If my memory serves me right, high sweat chloride is a gold standard for identifying cases of cystic fibrosis.
Oh wait, before you conclude, let's discuss the rest of the case.
No! Given all her pulmonary symptoms and the productive cough, I assure you, this is a case of cystic fibrosis.
Shut up! Let's proceed with this medical case.
Why don't you listen to me? This is a case of cystic fibrosis wherein there is an impaired CFTR gene. This enables chloride to diffuse into the periciliary fluid, causing decreased water composition, which creates thick sputum. Because of that excessive sputum, bacteria can easily colonize and create biofilms.
It might be, but we need to finish the medical history before concluding. At age 11, she lost 6 kilograms of her weight for over a period of 3 months, prompting another trip to the hospital. Upon admission, doctors noticed that she is a thin, cyanotic, and dyspneic child with barrel chest, which indicates a presence of pulmonary complications. The child also complained of suffering from excessive coughing and shortness of breath, as well as excessive thirst and frequent urination. That she states she needs to wake up several times at night just to relieve herself.
Well, that sucks, especially when the comfort room is far from your room.
Yeah, imagine you need to get up early for work or school and sleeping for only a few hours and then you wake up just to pee. Why do you think that happened?
I think that happened because of urinary incontinence. She mentioned she experienced excessive coughing, and these could lead to increased pressure on the pelvic floor, causing the urge to release the contents of her bladder. Am I right?
I agree to that. Add that to her excessive sweat production. That could lead to low salt levels and could affect the body's control of thirst. Maybe that's why she's very thirsty.
I remember you saying something about barrel chest. What is that?
Well, barrel chest happens when the lungs are overly inflated with air, so the rib cage stays partially expanded all the time. This makes breathing hard and could aggravate shortness of breath. The reason as to why this happened is...
Wait, let me guess. It's because she can't breathe properly, right? I've observed that it says she was a dyspneic child with cyanosis and frequent shortness of breath.
How correct you are, my friend. And the problem in her lungs would progress and will be explained as I go on.
Then, let's go on with the case.
Lab results reported that she has an elevated fasting blood sugar of 180 milligrams per deciliter, elevated postprandial blood sugar of 270 milligrams per deciliter, elevated glycosylated hemoglobin, as well as presence of sugar in the urine. These are said to be indications that she has now developed a problem in her kidneys. Her doctor advised that her parents should limit her sugar intake and to inject subcutaneous insulin. After 5 years, she still has difficulty in breathing upon exertion with cyanosis or bluish discoloration of her skin. Doctors advised her to start a nocturnal low-dose oxygen therapy.
So not only does she have a problem in her lungs, but her kidneys too? Poor kid.
Yeah, I also mentioned that she has manifestations of diabetes, which in this case is called cystic fibrosis related diabetes or CFRD. I know this is because CF causes changes in chloride conductance. It has been shown to alter beta cell functions where a decrease in intracellular chloride levels impairs depolarization in response to glucose levels that would normally trigger insulin release.
So this leads to the decrease in insulin secretion, explaining her elevated blood glucose level.
Yup. And do you remember when I told you that she lost 6 kilograms of her body weight for over a period of 3 months?
Yeah, that's the reason why she was hospitalized in the first place.
Well, that is because patients with CF either loses weight or fails to grow normally because their absorbed energy intake is less than their total daily energy expenditure. Multiple factors was said to have the potential to contribute to reduced energy intake like anorexia, gastroesophageal reflux, leading to vomiting and hence food loss, as well as maldigestion. However, another more recently recognized source of energy loss is glucosuria, as a result of CF-related diabetes I just mentioned.
That makes sense because she cannot use the carbohydrates that she ingests.
Uh-huh. At age 17, she has undergone a procedure called cardiac catheterization that reported an increase in both her pulmonary arterial pressure that had a value of 38 over 22 millimeter mercury and a pulmonary arterial mean pressure of 28 millimeter mercury, stating that there was no evidence of valvular disease or a septal defect. This has led her doctors to infer that her heart pumps with a greater force due to an obstruction present in CM's pulmonary circulation.
So now she has an obstruction in her lungs too? This little lady can't take a break.
Well, a defect in her CFTR gene leads to an impaired chloride transport, thus a reduction in the osmotic gradient that would lead to a decrease of water in the mucus that thickens it. This caused an obstruction in her lungs.
And this obstruction causes the increase in pulmonary arterial and mean pressure.
Yup, because this is not due to a valve disease nor a septal defect. A year later, she was given a physical examination and it was noted in the results that she has a higher rate of 120 beats per minute, respiratory rate of 30 at rest, which increased to 40 on slight exertion, presence of crackles at both lung fields, S2 sound split upon inhalation, pulmonic closure is equal to aortic closure, no murmur, and presence of extensive digital clubbing.
Whoa, hold up. That's a lot of information to digest in one breath. What is all that supposed to mean?
Well, remember when I told you that there's an obstruction in her lungs?
Mm-hmm.
This caused a significant decrease in her oxygen levels.
Well, so that means that this little lady cannot breathe properly.
You're right. This caused the increase in her respiratory rate that is exacerbated upon slight exertion. There's this interesting reflex called the Herring-Brewer, which is activated when there is pulmonary congestion.
Herring what? I can't herring you.
Herring-Brewer, Eeda. It happens during an obstruction in the lungs, wherein inspiratory effort is terminated before full inspiration is achieved, resulting in rapid and shallow breathing, thus increasing the respiratory rate.
Oh, so what happened?
She has hypoxia that could lead to pulmonary hypertension, increasing the capillary hydrostatic pressure that pushes the fluid from the capillaries toward the interstitial space, causing the crackles. The hypoxia caused the clubbing too.
Ooh, clubbing! Tugs, 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 tugs.
No! I meant clubbing of her fingers caused by the shunting of megakaryocytes and platelets in the digital vasculature due to hypoxia resulting to fingers and toes having the appearance of upside-down spoons.
Well, that's weird. Having a spoon for a finger?
So, going back to the case, this prompted her doctors to to check her heart and lungs by ordering an electrocardiogram and pulmonary function tests. The ECG yielded the following results: sinus tachycardia at the rate of 123 with normal intervals, an R-wave axis of positive 125 degrees, evidence of right atrial enlargement as well as right ventricular hypertrophy. Her pulmonary function still remains poor, and arterial blood gas showed a decrease in both partial pressure of oxygen of 52 mm mercury and pH of 7.26, but with an increase in both partial pressure of carbon dioxide of 59 mm mercury and bicarbonate of 31 milliequivalent per liter.
Wow, right ventricular hypertrophy? You mean this poor girl's heart had to literally compensate by increasing its muscle mass so that it can overcome the pressure in the pulmonary circulation? Damn. That's a really bad situation she got herself in.
Exactly. It's a really bad situation. At this point, she also has respiratory acidosis because air is trapped within the lungs due to decreased elastic recoil pressure and increased resistance in the airways caused by the same obstruction that I had mentioned earlier. I wouldn't wish this on anyone, not even my worst enemy. As you'll see, it's gonna get worse before it'll get better.
Jeez, there's more? Hasn't she been through enough?
Sadly, Eeda, yes, there's more. You ready?
Do I have a choice?
Well, our girl, 2 years later at the age of 19, was suddenly brought back to the hospital because she had a really bad fever and persistent coughing. Now, this kind of thing for her isn't new. She's been in and out of hospitals her whole life and she's probably experienced a fever or two. However, this time, her fever had reached almost 40 degrees, her pulse was above normal, and her respiratory rate was also increased.
Wow, that's pretty severe, huh?
It is. Her white cell count was, get this, 3,400 cubic milliliters, more than the average. It's so obvious from these labs that the infections are persistent. Her neutrophils were 91%. Do you know what normal neutrophil is supposed to be? It's 57 to 67%, Eeda. Just imagine how high her neutrophils are.
It is pretty high. I'm gonna go out on a limb here and say that the increased neutrophils are due to the continuous infection and inflammation cycles of someone who has cystic fibrosis. I mean, neutrophils are constantly recruited because of the infection. And yes, neutrophils generally should be helpful, but the damage that this does to the poor girl's lung tissue, my gosh, I can't imagine. Neutrophils release elastase, don't they? And these elastase cleave the bacterial protein, but because it's too much, it starts to wreck the girl's tissues, especially her lung where the infection's at.
I actually agree with you on that. I'm amazed you're making so much sense here. There are actually evidence to support your claims. We're talking lung tissue here, right? So her doctors did chest radiographs and it basically showed them that she has low lung volumes. Her lung's structural capacity isn't the best because the elastase has ruined it. So as a result, she gets bronchiectasis, where her airways become abnormally widened. This allows more mucus to seep in those already damaged airways, even further decreasing her lung volume.
Ouch! Tell me the doctors did something about it.
Yes, they did. They gave her cefuroxime, which is an antibiotic to help with the infection. And things shouldn't go well at this point, shouldn't it? Nope. Fate is cruel, and so no, things did not get better. She becomes unconscious the next day.
Wait, what? What happened to her? Tell me this isn't something the doctors couldn't fix.
Well, she wasn't able to take several doses of insulin in the past 3 days. So that happened.
So she's experiencing acidosis, I'm guessing, due to the accumulating ketone bodies from ketogenesis, since the glucose cannot be utilized.
Yup. But due to the fantastic world of modern medicine, the doctors corrected her acidosis. They continued to give her antibiotics. They also gave her IV fluids and insulin. Soon enough, her clinical and biochemical status improved.
Friendly reminder not to skip insulin doses, don't you think?
Yup, it was very unfortunate of her. to experience acidosis. It's as if cystic fibrosis wasn't bad enough.
That's true. So, tell me, she recovered?
Yup, actually, for the next 18 months, she'd visit her doctor, but that doesn't mean her lung condition got better. It actually got worse, way worse.
Come on, give her a break. Tell me there's suddenly a magic that could cure all of her conditions.
Well, not exactly. All her tests point to her pulmonary function steadily declining. She already receives bidirectional positive airway pressure at night, which assists in breathing. Despite this measure, when they did a CT scan, they saw all kinds of bad. She had cystic bronchiectasis of all lung lobes. This took place because, again, increased levels of elastase which damaged the lung tissue. Her oxygen saturation was below normal and mostly because gas exchange was no longer efficient due to the damaged lung tissue. They finally decided to do a lung transplant.
Ha! I knew it was a case of cystic fibrosis.
Well, we wouldn't understand it if we didn't discuss the patient's medical history. Was this enlightening to you?
It surely is. So, if you learned to, like and subscribe this video channel and comment down below on the topics you want us to solve next. And hit the ring button for notifications.